Hello, good day. This is Dr. Mirski from Johns Hopkins Medicine. I'm a professor of anesthesiology and critical care medicine. And today I am offering a brief tutorial on hypertonic fluids, when and how. I have no disclosures for this particular tutorial. Before we discuss exactly the use of hypertonic fluid, it is pertinent to look at how water is controlled in terms of its movement through the various vascular and extravascular compartments in our body. If you take a classic 70 kilogram human, we know that approximately 60% of all water is intracellular and 40% is, or 1/3 is extracellular water. And of that, we have a disposition towards intravascular and extravascular, which is approximately 3 and 11 liters. The 3 liters seems low, but if you include the roughly 1.6 liters of actual red cell mass, that's where you come up with the typical 4.8 or 5 liters of total blood volume in a 70 kilogram human. Now, water moves throughout these spaces relatively freely. It is solutes such as sodium, which is not free to move to every compartment, particularly in the intercellular compartment. Sodium is usually actively extruded out of the cells to maintain its membrane voltage, particularly in the brain. If you look at this disposition of water and ask yourself if you lost 1 liter of plasma here in this compartment and all we have to offer the patient is D5W, which essentially is free water, and ask how much water would it take to replenish this compartment back to 3 liters if we wait for equilibrium to occur with all of the water movement, you would actually have about 14 liters required to give to this patient to replenish that 1 liter lost compartment, because water, of course, will dispose everywhere in this gentleman or woman. If we had normal saline to accommodate to this individual, then the intracellular compartment is relatively excluded from this because sodium doesn't move typically into cells. So we're left with the 14 liter compartment, and we want to replenish this one. So it takes about 4.7 liters. If we actually had some hypertonic fluid, like 3% sodium, this is almost equal to a 1-to-1 exchange. And the use of hypertonic fluid actually pulls water from other spaces into the vasculature, and hence at 7.5% concentration, you get basically an added doubling of the total volume replenishment, as you only need half a liter in the intravascular space as an IV replenishment to get a full liter constituted back into the intravascular space. This strategy has been used successfully, mind you, in many publications on trauma, where it has been well documented that if you look, for example, in this representative trial, that reconstitution of mean arterial pressure and heart rate as physiological parameters of shock resuscitation show very clearly that use of hypertonic fluids does resuscitate patients faster than use of lactated ringers, which is the typical comparative fluid. However, most of these studies have been unable by their size to actually show a survival benefit, and it's not that unusual to believe this, since trauma, of course, is a multifaceted disease, and simple resuscitation in the first hour or so doesn't necessarily lead to survival with other things occurring. But it does show a trend typically that hypertonic fluids have a survival edge, and it is known that if you pool all these data sets together in a meta-analysis, there usually typically is an odds ratio benefit for survival with improved hemodynamics. And here I return to show you that one of the issues with trauma resuscitation trials is that relatively small volumes of hypertonic fluid are used. So it's not inconceivable that we haven't been able to see a major benefit in survival asking just this small resuscitation volume to be so effective. In addition to trauma in the field, similar resuscitation has been evaluated in the operating room setting in large blood loss cases, and it has been shown numerous times that hypertonic saline reduces the volume of intravenous fluid required to maintain people undergoing surgery. However, mortality benefit has not really been studied in this population. Other benefits of systemic hypertonic saline has included for a period of time the thought that critical care patients may benefit from infusions of hypertonic saline to reduce the inflammatory kickback, if you will, of critical illness. Here's a study in mice showing that indeed, if you create lung injury in the setting of hypertonic saline versus normal saline or normal osmolality, that the lung architecture seems to be better preserved in the hypertonic saline than in the inflammatory conditions seen here. And of course, and here showing basically 24 versus 72 hours that the hypertonic group shows less lung injury score. However, that has recently been translated in not really having a clinical benefit, because it's well documented that all types of cells in our bodies do not function at their best in a hypertonic medium. So neutrophil activation, for example, is not activated as rapidly in a hypertonic medium. Neutrophil movement isn't as great, but that doesn't really mean that the trauma or pathology to the tissue isn't there. And so we're just probably delaying a lot of the final inflammatory period and delaying it outward. One of the adverse effects to think about in systemic hypernatremia, I'll just give you one here, is that its effect on coagulation. Now, this has been a topic that many people raise, but the data presented here and in numerous other publications show that that really doesn't occur until you really begin to look at very high concentration of replacement fluid. In 7.5% or 10%, you actually will see a prolongation of the R and K times and the diminishment of the alpha angle in the TEG coagulation test. But underneath, below levels of 7.5%, you don't see much effect. Now, getting back to the brain, where we know that the brain is one of these singular organs that have tight junction endothelium as opposed to fenestrated junction, and hence excludes sodium and other ions rather well. And here's just an electron micrograph showing this sort of tight junction glue here separating these two cells. Now, hypertonic medium has been looked at to help prevent pathologies such as cerebral herniation, as you see here, an uncal herniation syndrome coming and compressing the third nerve. Both fluids such as hypertonic saline and mannitol, which is also a hyperosmolar fluid, have been evaluated and used clinically to help prevent cerebral brain edema from its consequences of elevated ICP and herniation. We did this study years ago looking at equal osmolar doses of mannitol versus hypertonic saline in a rat model, showing that in a trauma model where the ICP has risen to this sort of zero normal level, that the addition of either mannitol or hypertonic saline in the first hour nicely reduces ICP about 40% of its maximum, where this was the control level. Now, this is the important curve, I think, of that study, is that here again is normal control over several hours of peak ICP after an injury. And again, both hypertonic saline and mannitol decrease effectively the intracranial pressure, but whereas hypertonic saline takes a very long time to approach and never fully approaches back to its pre-bolus level of intracranial pressure even after 500 minutes. The mannitol only lasts about an hour or two, and then, as you see, it actually rebounds, as we call it, over and above the baseline ICP. So that is a sort of adverse potential effect of mannitol, which has been demonstrated both experimentally and in the clinical setting, which shows that even after a single bolus, mannitol may leak through the altered blood-brain barrier near gliomas or in areas such as stroke or trauma. And hence, since mannitol is then sequestered in brain, but is actively secreted from plasma as a non-metabolized sugar, there will come a time when the plasma-to-blood osmotic gradient will actually shift. And water will now tend to go into brain because mannitol is still there and it's not in plasma. Thus, it may aggravate edema and promote rebound ICP. Hypertonic saline doesn't have that attribute because it is not as actively excreted as mannitol from the kidneys, and also because it doesn't sequester. It will just come up and equal the gradient across different barriers very easily. There's been a number of articles published clinically to show benefit of hypertonic saline in different circumstances, primarily for preventing or reducing herniation syndromes. The main consequence of using these elements is that once you provide sodium in the external environment, you lose water. And mind you, hypertonic saline is transient in its efficacy because over time, meaning minutes to hours, a cell will re-equilibrate by introducing sodium intracellularly to maintain its cell volume. And if you maintain a patient or a cell in a chronic hypertonic state, rather than introducing sodium at high levels, the cell actually synthesizes osmotic organic osmolytes, such as amino acids and myoinositol, to help maintain cell volume. However, that being said, continuous controlled use of hypertonic saline in an ICU environment has been shown to be very stable over time, and patients have not deteriorated through prolonged use of this. The main issue is that once you have a hypertonic state, you need to take a very long time to gently reduce the serum osmolarity carefully because of the high osmotic organic osmolyte load in the cell, and you want to prevent a rebound effect. So it takes days to do that. Here's just some couple of potential toxicities of hypertonic saline. None of them are been found clinically to be very prominent. And another osmolar drug like mannitol has, unfortunately, more potential toxicities that are clinically prominent, as we talked about. So salient points: the isotonic fluids are not as well, excuse me, hypertonic fluids are better used for resuscitation, and as long as you use judicious manner of controlling the timing, then the risks of using hypertonic solutions are effectively negated. But there's solid evidence for reduction of ICP, cerebral water, and as a resuscitation fluid.